Question 1. To careful analysis of a treatment plan for a patient with a mediastinal tumor, Dr. Collin notices discrepancies in dose delivery predictions near the spinal cord. The CT-based planning system underestimates the dose received by this region despite no apparent setup error. A physicist reviews the mass and linear attenuation coefficients used for soft tissue and bone. What is the most likely explanation for the dose miscalculation? A. Incorrect calibration of the ionization chamber used in commissioning. B. The CT number to electron density conversion table used was outdated. C. The treatment couch attenuation was not included in the plan. D. Misalignment in beam collimation with spinal protection structures. Answer. Correct answer. B. The CT number to electron density conversion table used was outdated. Explanation. An outdated Hood density table can misrepresent tissue heterogeneities, especially at bone-soft tissue interfaces. This impacts attenuation calculations and dose distributions in TPS. According to OPA TG65 and TG105, accurate Hood density calibration is essential for dose-accurate. Heterogeneous regions, options A, C, and D, could cause other issues but are less directly linked to systematic underestimation of dose in specific regions due to electron density conversion errors. Question 2. In light of recent developments, a new hyperfractionated protocol is proposed for prostate cancer treatment using 7.25 Gi per fraction for 5 fractions. A physicist is tasked with evaluating the biological equivalence of this regimen to the standard 7-8 Gi in 39 fractions, 2 GIFs. Assuming AB ratio of 1.5 Gi for prostate cancer, which of the following reflects the biological ration? For hyperfractionation in this case, a lower AB ratio of tumors leads to better sparing of normal tissue in high dose per fraction. B. Lower AB ratio implies tumor cells are more sensitive to fraction size, favoring hypofractionation. C. Higher AB ratio enhances tumor control through repair mechanisms. D. High dose per fraction reduces treatment time and tumor repopulation significantly. Answer. Correct answer. B. Lower AB ratio implies tumor cells are more sensitive to fraction size, favoring hypofractionation. Explanation. The LQ model indicates that tissues with low AB ratios like prostate are more affected by changes in fraction size. Hypofractionation exploits this by delivering fewer high-dose fractions, achieving similar or higher biological effect. OPA TG137 and ICRU Report 91 support the use of hypofractionated schedules when AB is low. Option A misrepresents the effect on normal tissue. C is incorrect as repair capacity is not directly tied to AB. D is true but not the biological rationale. Question 3. As illustrated by a CAR test involving daily output constancy, a resident physicist uses a pharma-type ionization chamber in solid water and observes a deviation of 3.7% from baseline. The LINAC has not shown any performance alerts and environmental conditions are stable. Which factor is most likely responsible for the observed deviation? A. The electrometer has degraded and introduces bias in charge readings. B. The temperature and pressure correction was not applied correctly. C. The phantom material used is not water equivalent for photons. D. The radiation field size used during measurement was non-standard. Answer. Correct answer. B. The temperature and pressure correction was not applied correctly. Explanation. Ionization chambers are sensitive to air density changes. The charge collected must be corrected using temperature pressure factors KTP. Neglecting or misapplying this results in significant dose measurement error. According to EATRS 398 and OPA TG51, failure to correct for atmospheric conditions is a common source of deviation. Options A, C, and D are less likely to cause a consistent daily deviation of this magnitude. Question 4. Dr. Y, a radiation oncologist, consults with physicist Priya regarding target delineation for a head and neck cancer case. Due to variability in swallowing motion during planning CT, there is concern about adequate coverage of the posterior pharyngeal wall. Priya recommends expanding the clinical target volume CTV margins but ensuring sparing of the spinal cord. What is the most appropriate next step? A. Increase the PTV margins symmetrically to account for motion. B. Use MRI fusion to improve soft tissue delineation and redefine the GTV. C. Apply a non-uniform CTV to TV margin using motion data and art. D. Shift the spinal cord or contra way to reduce its dose. Answer. Correct answer. C. Apply a non-uniform CTV to TV margin using motion data and art. Explanation. Anisotropic margins are appropriate when motion is directionally dependent, especially in regions with physiologic motion like swallowing. Adaptive radiotherapy and forward imaging can quantify this and support margin reduction while sparing ores. This aligns with ICRA 83 and ESTRO guidelines. A. Risks overdose to ores. B. May EDTV definition but doesn't address motion. D. Violates ore delineation integrity. Question 5. The implications of using pencil beam scanning in proton therapy include sensitivity to tissue heterogeneities and setup errors. A physicist is planning a treatment for a pelvic sarcoma butting bowel gas-filled loops. What range uncertainty mitigation technique is most suitable? A. Implement robust optimization including setup and range uncertainty margins. B. Use passive scattering techniques instead of PBS. C. Increase the number of fields to average out uncertainties. D. Prescribe dosing gray instead of gray or B. Answer. Correct answer. Implement robust optimization, including setup and range uncertainty margins. Explanation. Robust optimization accounts for inter- and intrafractional variability, especially in proton plans. This method is crucial when tissues like bowel gas introduce variable stopping power. According to OPA-TG 185 and ESTRO particle therapy guidelines, it's the standard method to mitigate range uncertainties in PBS. Options B and C have merit but are less direct. D does not address range uncertainty. Question 6. MS Alvarez is undergoing HDR intracavitary brachytherapy for cervical cancer. During applicator insertion, the tandem is angled more anterior than intended. The physicist is tasked with adjusting the treatment plan. What action is most appropriate to ensure treatment safety and efficacy? A. Proceed with treatment as the dose constraints were met. B. Recalculate dose based on the current applicator position using new imaging. C. Manually adjust dwell times without new imaging. D. Increase dose to the target to compensate for the anterior shift. Answer. Correct answer. B. Recalculate dose based on the current applicator position using new imaging. Explanation. Accurate source positioning is critical in HDR brachytherapy. Any applicator misplacement must be verified with imaging, and a new plan must be generated. This is mandated by ICRA 89 and OPA-TG 43. Proceeding without new calculations, a CD risks overdosing ores or underdosing the tumor. Question 7. From a practical standpoint, which of the following best reflects the reason for using reference glass ionization chambers during LINAC photon beam calibration? A. They measure the actual energy spectrum of the beam. B. They are less sensitive to dose rate variations than other detectors. C. Their response is independent of environmental conditions. D. Their geometry and reproducibility meet strict international standards. Answer. Correct answer. D. Their geometry and reproducibility meet strict international standards. Explanation. Reference glass chambers e.g. per IC 60731 offer reliable, reproducible, and traceable measurements. OPA-TG 51 and EATRF 398 specify their use for absolute calibration due to their well-characterized response and geometry. Options A, B, and C are incorrect or oversimplified. Question 8. Considering the evidence, why does photoelectric absorption dominate over Compton scattering in diagnostic X-ray imaging of bone? A. Because bones have a lower atomic number than soft tissues. B. Because Compton scattering is more likely at low photon energies. C. Because photoelectric absorption probability increases with Z and low energy. D. Because Compton scattering depends on atomic number square. Answer. Correct answer. C. Because photoelectric absorption probability increases with Z and low energy. Explanation. Photoelectric effect equals Z, making it dominant in high Z materials like bone at diagnostic energies 2 euro, 1 2 euro keV. Compton is more dependent on electron density. ENRP report 102 and physics literature confirm this. A is false. B misrepresents Compton. D incorrectly describes Compton's dependence. Question 9. During an HDR afterloader car procedure to Thompson, the medical physicist notices that the source fails to retract after a dummy run. The patient is not yet in the room, but the source is extended. What is the immediate next step? A. Power off the afterloader to reset the system. B. Temp manual source retraction as per the emergency protocol. C. Call service personnel to handle the source retrieval. D. Proceed to continue the cut as the source is not emitting significant dose. Answer. Correct answer. B. Temp manual source retraction as per the emergency protocol. Explanation: HDR devices must have emergency retraction protocols in case of source malfunction. OPA TG59 and NRC regulations mandate staff be trained in manual retraction. A. Risks trapping the source. C. Delays response. D. Dangerously downplays source risk. Question 10. The fundamental question is, how does RBE influence the dose prescription for carbon ion therapy compared to conventional photon therapy? A. A higher RBE reduces the need for dose optimization in normal tissues. B. RBE adjusts the dosing carbon ions to achieve equivalent biological effect. C. Lower RBE of carbon ions requires a higher total dose than photons. D. RBE is irrelevant in clinical dose calculation for heavy ion therapy. Answer. Correct answer. B. RBE adjusts the dosing carbon ions to achieve equivalent biological effect. Explanation. RBE reflects how biologically effective a radiation type is compared to reference photons. For carbon ions, RBE1 means a low physical dose achieves similar biological effect. This is factored into treatment planning. See ICRU Report 93 and ESTRA Particle Therapy Guidelines. A, C, and D are incorrect. Question 11. In the context of radiation dosimetry, a patient is undergoing treatment where ionizing radiation is being delivered. Which of the following factors must be considered in ensuring accurate dose delivery for the patient? A. The rate of photon energy deposition within the patient. B. The relative biological effectiveness, RBE, of the radiation. C. The patient's tissue composition and density variations. D. The level of radiation shielding used during treatment. Answer. Correct answer. C. The patient's tissue composition and density variations. Explanation. In radiation dosimetry, accurate dose delivery depends heavily on the patient's tissue composition and the variations in tissue density. This affects the absorption and attenuation of radiation. Tissue density variations influence the way radiation interacts with different body parts, making it essential for treatment planning. For example, adipose tissue attenuates radiation differently than muscle tissue. The linear attenuation coefficient is influenced by tissue type and density, which is crucial for precise dose delivery. While RBE, energy deposition, and shielding are relevant, they don't directly impact the dose calculation as tissue density does. Question 12. Given the circumstances Mr. Thomas, a radiation therapist, is working with a patient who is being treated using proton therapy, which of the following considerations is most important when planning the treatment for this patient? A. The dose distribution and the Bragg peak. B. The shielding requirements for the treatment room. C. The patient's age and medical history. D. The amount of time required for patient setup and positioning. Answer. Correct answer. A. The dose distribution and the Bragg peak. Explanation. Proton therapy is based on the principle of the Bragg peak, where the maximum dose is delivered at a specific depth within the tissue, followed by rapid dose fall-off. This makes proton therapy particularly advantageous for tumors located near critical structures. Treatment planning for proton therapy needs to focus on accurately locating the Bragg peak and ensuring that it coincides with the tumor volume. While patient factors like medical history, positioning, and shielding are important, they do not influence the treatment as directly as understanding the Bragg peak and dose distribution. Question 13. To better understand the biological effects of ionizing radiation, which model is most commonly used to estimate cellular response to varying radiation doses, and how does it apply to fractionation and dose rate effects? A. The linear quadratic LQ model. B. The biologically effective dose bed model. C. The relative biological effectiveness, albeit model. D. The tumor control probability TCP model. Answer. Correct answer A. The linear quadratic LQ model. Explanation. The linear quadratic LQ model is the most commonly used to estimate the cellular response to ionizing radiation, particularly when considering fractionated radiation therapy. It accounts for the effects of both low and high dose radiation by modeling cellular damage. This model is especially helpful when analyzing dose rate effects and how tumor and normal tissue respond to fractionation schemes. The LQ model predicts that at low doses per fraction, the quadratic component becomes more significant, whereas at higher doses per fraction, the linear component dominates. This helps optimize treatment planning. Question 14. The growing trend in adaptive radiation therapy emphasizes the need for real-time adjustments in the treatment plan. What is the primary advantage of ART in radiation oncology? A. It ensures the tumor is treated according to the original plan regardless of any changes. B. It allows for the reduction of treatment time and increased patient throughput. C. It enables real-time adjustments to account for changes in tumor size, shape, and position during treatment. D. It eliminates the need for imaging guidance during treatment delivery. Answer. Correct answer. C. It enables real-time adjustments to account for changes in tumor size, shape, and position during treatment. Explanation. The main advantage of adaptive radiation therapy is the ability to adjust the treatment plan in real time to account for changes in tumor size, shape, and position during the course of treatment. This is especially important for tumors that may shift or shrink during therapy. Unlike traditional methods where the plan is fixed, ART allows for modifications in response to daily changes, improving the precision of dose delivery. While ART requires additional imaging, it doesn't eliminate the need for it, but rather incorporates it into the treatment process. Question 15. Considering the principles of radiation protection, what is the most effective approach to minimize radiation exposure for healthcare workers during patient treatments in radiation oncology? A. Reducing the radiation dose to the patient. B. Increasing the time spent in radiation treatment areas. C. Maximizing the use of protective barriers and shielding. D. Encouraging workers to work in the same location continuously for exposure consistency. Answer. Correct answer. C. Maximizing the use of protective barriers and shielding. Explanation. The primary principles of radiation protection are justification, optimization, and limitation. To minimize radiation exposure to healthcare workers, the most effective strategy is to use protective barriers and shielding. This includes lead aprons, shielding walls, and remote-controlled treatment devices. The time spent in the radiation treatment area should be minimal, but the key strategy is physical shielding. Properly designed barriers and shielding systems ensure that radiation is contained and workers are protected without compromising the patient's treatment quality. Question 16. From a practical standpoint, in proton therapy, what is the main factor affecting the precision of treatment delivery when dealing with the variability in tissue composition? A. The relative biological effectiveness (RBE) of protons. B. The dose distribution curve for protons. C. The density of tissues and the calculation of range uncertainties. D. The type of proton being used during treatment. Answer. Correct answer. C. The density of tissues and the calculation of range uncertainties. Explanation. The precision of proton therapy treatment is significantly influenced by the density of tissues and the calculation of range uncertainties. Proton therapy relies on delivering the dose at a precise depth, known as the Bragg peak. Tissue density impacts the range of protons, which can cause deviations in dose delivery. Accurately accounting for these uncertainties and variations in tissue composition is crucial for treatment success. While RBE and beam types play a role, they do not directly influence the precision of treatment as much as understanding range uncertainties and tissue density. Question 17. The most significant aspect of quality assurance in radiation oncology involves which of the following? A. Verifying the radiation therapy equipment's calibration and output consistency. B. Ensuring the tumor's genetic composition is thoroughly analyzed. C. Conducting weekly patient follow-ups to monitor side effects. D. Reducing the overall cost of the treatment protocol. Answer. Correct answer A. Verifying the radiation therapy equipment's calibration and output consistency. Explanation: the most significant aspect of quality assurance in radiation oncology is ensuring that the radiation therapy equipment is accurately calibrated and consistently outputs the correct dose. This is fundamental to providing safe and effective treatments. CAR procedures involve frequent checks and tests of the equipment to ensure it delivers prescribed dose accurately. Genetic analysis, side effect monitoring, and cost reduction are important, but they do not directly address the immediate need for equipment reliability, which is central to CAR in radiation oncology. Question 18. What would happen if a patient undergoes radiation therapy with incorrect tissue volume delineation, particularly in terms of the target volume? A. The dose distribution will be tailored to the tumor's exact size and shape. B. The surrounding normal tissues may receive unintended radiation doses. C. The tumor's response to radiation will improve. D. The treatment duration may be reduced significantly. Answer. Correct answer. B. The surrounding normal tissues may receive unintended radiation doses. Explanation: incorrect tissue volume delineation can result in the surrounding normal tissues receiving higher than intended radiation doses. Accurate delineation of the target volume, such DEET, is critical for ensuring that the tumor receives the prescribed dose while minimizing damage to healthy tissues. If the target volume is not correctly defined, it can lead to overradiation of normal tissues, causing unnecessary side effects or complications. Proper delineation is therefore essential to the effectiveness and safety of radiation therapy. Question 19. In terms of radiation protection, what is the primary goal when designing radiation shielding for a treatment room in radiation oncology? A. To increase the radiation exposure to ensure therapeutic effect. B. To restrict radiation leakage and prevent exposure to non-target areas. C. To minimize the number of patients treated in the room. D. To lower the energy levels of the radiation beams. Answer. Correct answer. B. To restrict radiation leakage and prevent exposure to non-target areas. Explanation: the primary goal of radiation shielding is to restrict radiation leakage and prevent unnecessary exposure to non-target areas, including adjacent rooms, equipment, and personnel. Shielding is designed based on factors such as the type of radiation, e.g., photons, protons, the treatment energy, and the layout of the facility. Proper shielding ensures that only the tumor and surrounding tissues are irradiated, while minimizing the risk to other areas of the body and the environment. It's crucial for radiation safety regulations and to protect both patients and staff. Question 20. In light of recent developments, what role does proton therapy play in radiation oncology compared to traditional photon therapy for treating tumors near critical structures? A. Proton therapy has no significant advantage over photon therapy. B. Proton therapy offers greater precision, reducing damage to surrounding tissues. C. Proton therapy is less effective for tumors near critical structures than photon therapy. D. Proton therapy is only used for palliative care in radiation oncology. Answer. Correct answer. B. Proton therapy offers greater precision, reducing damage to surrounding tissues. Explanation: proton therapy offers a significant advantage over traditional photon therapy, especially when treating tumors located near critical structures. The unique characteristic of proton therapy is its Bragg peak, which allows for maximum dose delivery at the tumor site while sparing surrounding healthy tissues. This precision is particularly beneficial to tumors near sensitive organs like the spinal cord, brain, or eyes, where traditional photon therapy may cause collateral damage. Therefore, proton therapy is proven to be more effective for tumors near critical structures, offering a safer and more targeted approach. Question 21. In the context of external beam radiation therapy, which factor is most crucial for determining the treatment technique to be used for a specific tumor? A. The tumor's distance from critical organs. B. The patient's age and comorbidities. C. The type and location of the tumor. D. The patient's psychological response to treatment. Answer. Correct answer. C. The type and location of the tumor. Explanation: the treatment technique in external beam radiation therapy is primarily determined by the type and location of the tumor. Factors like tumor histology and proximity to critical structures influence the selection of treatment techniques, such as whether to use conventional photon therapy or proton therapy, while factors like patient age and comorbidities are important, do not primarily dictate the choice of treatment technique. Question 22. When utilizing image-guided radiation therapy, IGIT, which of the following is the key benefit of incorporating frequent imaging during treatment? A. It increases the dose delivered to the tumor. B. It ensures treatment accuracy by adjusting for tumor motion. C. It eliminates the need for patient immobilization. D. It reduces the overall cost of the treatment process. Answer. Correct answer. B. It ensures treatment accuracy by adjusting for tumor motion. Explanation. Image-guided radiation therapy (IGIT) allows for real-time imaging during treatment, helping to adjust for tumor motion due to breathing, organ shifts, or patient movement. This improves the accuracy of radiation delivery to the tumor while minimizing radiation exposure to surrounding healthy tissues, while immobilization, dose adjustments, and cost are all factors. The primary benefit of IGIT is improving treatment precision. Question 23. In radiation oncology, which of the following best describes the term? Tumor control probability (TCE). A. The likelihood that a tumor will grow despite radiation treatment. B. The probability that radiation will cause an irreversible genetic mutation in the tumor cells. C. The likelihood of eradicating a tumor with the prescribed radiation dose. D. The probability of side effects occurring due to radiation exposure. Answer. Correct answer. C. The likelihood of eradicating a tumor with the prescribed radiation dose. Explanation. Tumor control probability (TCP) is a model used to estimate the likelihood of eradicating a tumor given the prescribed radiation dose and the biological characteristics of the tumor. It is an important concept in radiation treatment planning and helps guide decisions regarding dose escalation and treatment strategies. It directly relate to side effects or genetic mutations, although those are also important considerations in treatment. Question 24. In radiation oncology, which of the following is the most important aspect when designing a treatment plan for a pediatric patient? A. Minimizing the overall treatment duration. B. Accounting for the potential long-term side effects and secondary malignancies. C. Increasing the radiation dose to compensate for slower tumor growth. D. Focusing exclusively on tumor size and location without considering other factors. Answer. Correct answer. B. Accounting for the potential long-term side effects and secondary malignancies. Explanation. When treating pediatric patients with radiation therapy, one of the most important considerations is the potential for long-term side effects and secondary malignancies. Children are more sensitive to radiation due to their developing tissues and longer life expectancy, meaning that the effects of radiation may not become apparent until many years. Treatment. Hence, minimizing radiation dose while still achieving effective tumor control is critical. Question 25. Which of the following radiation therapies is most commonly used for treating localized prostate cancer with minimal risk to surrounding organs? A. Stereotactic body radiation therapy (SRT). B. Proton therapy. C. Intensity modulated radiation therapy (IMIT). D. Brachytherapy. Answer. Correct answer. C. Intensity modulated radiation therapy (IMIT). Explanation. Intensity modulated radiation therapy (IMIT) is one of the most commonly used techniques for treating localized prostate cancer because it allows precise delivery of radiation to the tumor while sparing surrounding critical structures, such as the bladder and rectum. IMIT utilizes multiple small beams of varying intensities, which can be adjusted to conform to the shape of the tumor, providing better sparing of normal tissues compared to traditional radiation techniques. Question 26. In radiation oncology, which of the following is a significant advantage of utilizing stereotactic radiosurgery (SRS) for brain tumors? A. It requires multiple treatment sessions over several weeks. B. It delivers a high dose of radiation in a single session with minimal surrounding tissue damage. C. It is best suited for large tumors in difficult-to-reach locations. D. It can be used to treat tumors in multiple organs simultaneously. Answer. Correct answer. B. It delivers a high dose of radiation in a single session with minimal surrounding tissue damage. Explanation: stereotactic radiosurgery (SRS) is a non-invasive technique that delivers a highly focused dose of radiation to a tumor in the brain with precision, typically in a single session. This is particularly advantageous for small, well-defined tumors. SRS minimizes damage to surrounding healthy tissues due to the precision of the radiation beams. It is not typically used for large tumors or tumors in multiple organs. Question 27. When considering the radiobiological effect of fractionation, what is the primary reason for delivering radiation in multiple smaller doses rather than a single large dose? A. To enhance tumor cell destruction by allowing for repopulation of normal tissues between doses. B. To reduce the likelihood of tumor resistance to radiation. C. To exploit tumor sensitivity to lower doses of radiation. D. To allow for tumor shrinkage and adjustment of treatment planning between doses. Answer. Correct answer: D. To allow for tumor shrinkage and adjustment of treatment planning between doses. Explanation: fractionating radiation therapy into smaller doses allows for several benefits, including the ability to adjust treatment plans based on tumor response. It also reduces the risk of excessive normal tissue damage by giving healthy tissues time to repair between doses. Tumor shrinkage between doses is an important factor as it can improve accuracy of subsequent treatments and ensure better sparing of surrounding tissues. Question 28. In brachytherapy, which of the following is the most significant factor in determining the optimal placement of radioactive sources within the tumor? A. The proximity to healthy organs. B. The patient's age and comorbidity. C. The radioactive half-life of the isotope used. D. The size, shape, and location of the tumor. Answer. Correct answer: D. The size, shape, and location of the tumor. Explanation: in brachytherapy, the placement of radioactive sources directly within or near the tumor is critical for maximizing the radiation dose to the tumor while minimizing exposure to surrounding healthy tissue. The tumor's size, shape, and location are the most significant factors in determining where to place these sources. The radioactive half-life of the isotope and patient-specific factors are important but secondary to tumor characteristics. Question 29. What is the primary purpose of using proton therapy over conventional photon therapy in treating tumors near sensitive structures like the spinal cord or optic nerves? A. Proton therapy provides a higher dose to surrounding normal tissues. B. Proton therapy is more cost-effective than photon therapy. C. Proton therapy allows for more precise delivery with minimal damage to surrounding tissues. D. Proton therapy is used for palliative care and not for curative treatment. Answer. Correct answer: C. Proton therapy allows for more precise delivery with minimal damage to surrounding tissues. Explanation: proton therapy is particularly advantageous for tumors near critical structures such as the spinal cord or optic nerves due to its unique physical properties. Protons deliver most of their energy at a specific depth, known as the Bragg peak, and then rapidly fall off, minimizing radiation exposure to surrounding healthy tissues. Precision is especially beneficial for treating tumors in sensitive areas where conventional photon therapy may cause excessive damage to healthy tissues. Question 30. In radiation oncology, which of the following models is most commonly used to estimate the relationship between radiation dose and the likelihood of treatment success or failure? A. The linear quadratic LQ model. B. The exponential survival model. C. The Poisson distribution model. D. The biologically effective dose bed model. Answer. Correct answer: A. The linear quadratic LQ model. Explanation: the linear quadratic LQ model is the most widely used model in radiation oncology to estimate the relationship between radiation dose and the probability of treatment success or failure. It accounts for both the linear and quadratic effects of radiation dose on cell survival, which helps in determining optimal treatment doses and fractionation schedules. The bed model also uses the LQ model but adjusts for different fractionation schemes, but the LQ model remains the most commonly applied.